Welcome everyone who is here to the GIACE weekly series. This is a series that the Global Integrity Anti-Corruption Evidence Program has been putting on in the last few months, where we ask each of our different research projects to come and join us in a conversation where they talk about some of the research findings and policy recommendations that they've been able to derive after several years of work. Today, I'm really pleased to introduce the principal investigator on a really interesting project, Professor Ryan Jablonski from the London School of Economics, who is joined by some research team members, Mariana, a PhD candidate from the University of California, San Diego. They are going to be discussing their project that looks at identifying and deterring medication theft, focusing specifically on the case in Malawi. Before I let Ryan start his presentation, I'm going to quickly run through the Global Integrity Anti-Corruption Evidence, or the GIACE program, and some of the core principles that underpin these projects. The founding principles of GIACE are that research should be problem-focused on anti-corruption and not just explore the way corruption manifests and the damage that it incurs. Projects should be issue-driven and specific and not apply a prescriptive one-size-fits-all solution to corruption. It should address real-world priorities and incentives in specific sectors and should take into account political will, focusing on politically viable reforms. I know that this is something that has been of a lot of interest and focus of this project, and so I'm interested in hearing on how they've been able to tackle that particular challenge. Also importantly is that we've asked the project's mandate is that they are able to engage policymakers and practitioners from nose to tail of the research process, something that this project has also been able to do very effectively. So I'm going to let Ryan take it away, but feel free to direct any questions that you might have in the chat or message me personally. My colleague Paul Haywood is going to be moderating the conversation at the end of the presentation. And so, yeah, feel free to have an engaging discussion, getting in touch with our researchers. You can go ahead, Ryan.
Great, thanks, Vero. So as Vero said, I'm Ryan Jablonski, and this is a large project with a number of collaborators looking at some of the things we can do to identify and prevent medicine theft in the developing world. And I'm particularly going to focus on the case of Malawi today, where we've been working for about 3 years on this particular question. And we have a number of partners on this. I want to thank especially the ACE Global Integrity Program, who helped to fund us and have really, held our hand through a lot of this work. We're also supported by the World Bank, and one of our main partners is the Ministry of Health in Malawi. And then we also have a technology partner, as I talked about, called On Asset. And what this project is about is really trying to tackle what I would call one of the biggest public health issues that countries like Malawi face, which is that medicines that are provided both by the government and by donors very frequently are either disappearing or are not used effectively or are allocated inefficiently. And this, as I'll talk about in a second, right? This is a huge problem, both with respect to the economics of public health within societies like Malawi, but also as very, very large public health consequences with respect to people's ability to access needed and life-saving drugs. So what I'm going to do today is frame the problem a little bit, talk a little bit about why this is such an important policy issue, what we think some of the main policy problems are. And then I'm going to go into some of the research we did, both trying to scale this effect, right? How frequently is medicine going missing? And then I'll go into a little bit of some ways that ways we're trying to use some new digital audit technologies to try to both identify theft and deter theft. And I want to say that this is still fairly, even though we've been working on this for some time, a lot of the data I'm going to present today is newly collected and fairly early. So I'm going to caution that some of what I'm going to present is very preliminary and should be interpreted with some caution. But to get started on this, I want you to note that the diversion of drugs and the theft of drugs is one of the world's biggest health challenges. Now, this is, of course, incredibly difficult to measure, but from data that we do have, which is frequently coming from audits of public health supplies, the best estimates that we have suggest that up to a third of public medicines are diverted to private markets in developing contexts. This is true in Malawi. It's also true, similar rates we've been observed in places like Bangladesh and Mozambique and Nigeria. And in Malawi specifically, this is a huge issue with respect to the public health system. Most estimates, for instance, from global funds suggest that about 29% of medicines are disappearing from the point at which donors give them to the country to the point they reach patients. As I'll talk about in a second, actually, as Mariana, my co-PI, will talk about, we find that about 75% of communities within southern Malawi have experienced the theft of medicines. The economic costs of this are quite great. So globally, it's likely that again, these are difficult numbers to really tackle, but the best estimates we have suggest about 10 to 25% of total global health spending is lost to corruption. And given we're talking about a $7 to $15 trillion global budget for public health, that's a huge economic cost. In Malawi, we're looking at about a third of Malawian health budgets, which are lost due to theft. This also implicates, of course, donors quite significantly. So the UK alone invests about 60 million pounds every year, mostly in the Malawian health system. So there's a huge cost both to governments and to citizens and to donors with respect to this level of theft and diversion. But most importantly, right, this has a huge public health cost. So I think it's probably not much of an exaggeration to say that corruption is one of the leading causes of preventable disease and mortality in a lot of developing countries with these kind of issues of low capacity and low accountability that I'll talk about. So almost all Malawians have suffered from issues of medicine stocking. So around 70% of all clinics in Malawi have had very severe issues of missing stocks. I shouldn't say missing stocks, but stocks that are not there that should be there. There are a number of reasons why that could be. But most frequently, Malawian, we'll talk about from our surveys that Malawians see these stocking issues as being largely driven by issues of theft from the Malawian health system. And also see this as a reason for poor healthcare in their communities. And then there's good evidence then that this impacts people's ability to get needed anti-malarial drugs in malaria season. This impacts people's ability to stay on schedule with antiretrovirals, and ultimately has large consequences on people's public health. The challenge, so I think none of that should be surprising to many of you, right? This is a huge problem. It's very costly in economic and health terms. So why does it still exist? Well, it's certainly not because there hasn't been a lot of attempts to solve it. Both donors and the government and citizens and health facilities have invested a lot of work in trying to solve this problem of theft, not only in Malawi, but in a lot of other contexts. So why has it been such an intractable problem? Well, I think that there's a few issues that we've identified in the course of our research. One is just the basic issue is this is a very profitable enterprise in a very low income society, right? Poverty is a core reason for theft. So, most even well-employed government pharmacists are making less than $200 a month on average. And the value of drugs going to many of these clinics is quite a bit beyond that. And related to that, of course, is the fact that theft is difficult to identify, right? The risk of getting caught is relatively low. And this is particularly true in Malawi due to the kind of weak supply chain, right? So I'm showing you an interesting picture I found quite illuminating from some work that we've done, some surveys we did in Malawi looking at procurement systems. And this is the procurement records at one clinic, and this is not unusual, right? And I would challenge you to try and figure out how you do an effective audit in a clinic with procurement records that look like that. And this is not surprising, or it's not unusual, right? But these kind of these issues of incomplete procurement systems and weak oversight mean it's quite difficult to identify theft. And this is particularly true in a lot of contexts like Malawi, where a large portion of the diversion and theft doesn't happen necessarily during official procurement activities, but rather at lower levels, right? By clinical officials, by pharmacists, by other individuals involved in the procurement supply chain, and it's quite and that kind of those kind of in between stages of procurement are very, very difficult to monitor. And existing audit mechanisms really don't give us a tool to go and do those kind of audits, right? Existing audit mechanisms that, for instance, that are being done by the government of Malawi are looking at whether or not drugs that leave central medical stores are arriving at local clinics. And this is a very limited view of what the actual nature of the medicine diversion issue is, given the fact that much of the diversion is happening outside of that first stage of the procurement system. And I'll talk about that a little bit in a second. So a main problem is these existing audit mechanisms and the technologies we have for dealing with theft and procurement in these kind of low capacity systems are quite imprecise, quite expensive relative to the returns, and don't really solve the problem. And then a final issue that we're going to try to get at a little bit in the conclusion of this talk is that that there's a real information gap with respect to medicine procurement in Malawi. So a lot of institutions exist that are supposed to provide accountability to the health system. We have citizen committees, we have drug theft investigation unit at the central government level. We have councils, we have chiefs that are involved in this, right? But many of these institutions don't really serve as an effective deterrent on theft. And one of the main reasons for this is that there's simply a lack of real-time data and information capacity, right? These institutions lack information on what drugs are arriving, what has been ordered, what has been received, when drugs are arriving, and lack the capacity to, even if they had that information, to both monitor effectively and to do something about it. So we're going to try to intervene a little bit and talk about some solutions that we think might work for some of these different areas. So what we did in the course of 3 years of research is first, at the beginning of the research, we did a fairly in-depth set of surveys and interviews of patients and clinical officials and health committees at 100 clinics. And you can see those more or less correspond to these blue dots that you see on the map here. Additionally, following those surveys and interviews, we conducted an audit of delivery activities in southern Malawi. So we tracked 2,400 medicines going to 170 facilities throughout southern Malawi. I'll talk a little bit more about that in a second, about how we did that and why we think that that worked well. But basically, we have data on exactly where all of those 2,400 medicines were delivered and where they were at each point in the procurement chain. Additionally, we conducted 2 in-person digital audits. And the digital audit here is not a traditional audit in the sense that we're checking paperwork, but rather audits that are relying on digital tracking devices in order to determine whether or not medicines have reached their intended location and whether or not they've been diverted at some point downstream on the supply chain. So we did 2 in-person audits at 144 public facilities. And then finally, we also did some digital audits at private markets and pharmacies to understand the extent to which government drugs are disappearing into private hands and try to scale the scale and effects of that diversion. And then finally, we did an experimental evaluation looking at the ways in which these kind of monitoring technologies and increasing the risks of getting caught for diverting medicines might impact the extent of theft and diversion. And I'm not going to talk about that much today because some of the analysis there is still ongoing, but that also is a key part of our research. All right, so from there, what I want to do is hand it off to my co-PI, Mariana, who is going to talk about the survey that we did at Baseline.
Hello, so I'll present some results from our survey that explored Malawians' experiences with assessing medicines. We surveyed around like 3,300 citizens from areas in the south of Malawi that included 97 clinics. And today we will talk about 4 main takeaways. Next. So first, about 2/3 of citizens have observed the illegal sale of medicines. So this on the left, we have the result of a survey experiment. It shows the estimated probability that there is theft at a particular facility. And this is the number that Ryan mentioned at the beginning. So the median facility has people observing the selling of medicines. In number of respondents, we have 2/3 of people saying that they observed people selling medicines that should have been provided for free. The vertical dashed line indicates the mean value. And the picture on the right is an example of people selling drugs in markets. And these are government-owned medicines. Next. The second takeaway is that most citizens blame theft for poor quality healthcare. So on the left, we see that 53% of respondents agree that theft of medicines keep people from getting high quality healthcare in their communities. And on the right, we have that 46% of respondents have been unable to access medications. And this is like, these numbers are validated by estimates. For example, there's one study by Global Fund that estimates that 70% of all clinics have stockouts in Malawi. So this corroborates what we are seeing here. Next. So the third takeaway is that information and capacity gaps are a severe constraint, and they prevent people from reporting theft. So again, here 53% of respondents, sorry, on the left, said that the lack of effective ways to report the diversion of medications is a very important reason for why people choose to steal medications in Malawi. And another very important reason is that overall people do not know whether medications in their clinic were stolen. So on the right, we also have 53% of respondents agreeing that this is a very important issue. Next. The fourth takeaway is that formal accountability institutions are weak in Malawi. In addition to our survey with citizens, we also had a survey with HAC members in the same villages. Health advisory committees, as we call like HACs, are responsible for drug monitoring, among other duties. However, we have observed here that the HACs have been ineffective in overseeing deliveries of medicines. So the first graph shows that the number of deliveries witnessed by HAC members in the past 3 months, and 26% of respondents have said that they haven't witnessed a delivery, and around 23 said that they witnessed only 1 delivery in 3 months. And when we look at the survey with citizens, so the graph on the right, like they basically say that HACs are not very effective. So it's not only that HACs are not observing deliveries, but they are also not perceived as very effective by their communities. We also collected qualitative information on HACs with not only with the survey, but also with focus groups. And common answers for why HACs haven't been very effective are mostly related to lack of capacity and training. And so I think that the main takeaway here is that there are issues in reporting and transparency. And if we look at the behavior of the institutions that are supposed to be there and prevent theft, they are also very not effective. Next.
All right, so thanks, Mariana. I will take it from there now and talk a little bit about some of the audits that we did. So as Mariana, I think, nicely illustrated, what we're finding is that one of the main challenges with drug theft, with preventing drug theft in Malawi, is simply that there's not enough information about where medicines are going, and that the risks, and as a consequence, the risks of getting caught for theft are quite low. And so we see as one potential way to solve this problem is to use some of the advances in digital technologies to understand where and how drugs are being distributed within Malawi. So the way we did this is we used a set of devices by a company called On Asset, who's one of our core partners on this research. And what they do is they specialize in things like vaccine tracking and other forms of medicine tracking in order to primarily aid logistics companies in understanding where medicines go. And our innovation from a technology side is to say, well, let's take these devices and also use them in fairly low capacity contexts as a kind of audit device to understand not where things go from a logistics standpoint, but instead to sample medicines randomly, as you would through an audit, and try to understand with these devices which medicines are going where they're supposed to and which are not. So this is a picture of the device that you see on the left that we place either on or within medicines, 2,400 medicines, leaving central government medical stores. These medicines are then packaged within boxes and then shipped to various locations. Now, these are not autonomous GPS devices themselves. Rather, they're Bluetooth devices that then communicate with a separate receiver, which is a GPS device and a cellular device, which then allows us to know where each medicine is at each particular period of time, when it leaves trucks, and some other various characteristics of what's going on with those medicines during the time that they're being tracked. So to understand what we did with the audits, it's useful to say a little bit about the procurement system within Malawi. So this is a very simplified plot that I put you of how medicines get to patients. So in Southern Malawi, we have an organization called Central Medical Stores Trust, which is a parastatal organization, a parastatal company rather, that is responsible for storing medicines and organizing through independent logistics companies the delivery of medicines to government health facilities. Now, this can happen in one of two ways. Either it can happen from a direct delivery from central medical stores to health facility pharmacies. So there's about 200 health facilities in Southern Malawi that we're looking at. Alternatively, what can happen is central medical stores can deliver medicines to a district health office, frequently a hospital, and then that district health office will redistribute medicines as they're needed to particularly smaller clinics throughout Southern Malawi. At that point, they're stored frequently in a pharmacy or some secure facility within a health facility, or what's supposed to be a secure facility. And then they're reallocated to some kind of treatment ward or to a doctor or to a nurse or provider, at which point the medicines are allocated to patients. Now, there are a number of ways, there are a number of points on this procurement chain where medicines can go missing. Right? Perhaps the one that we think of most is this link, right? The link between medicines leaving central medical stores and going to a pharmacy. And so this is what a traditional audit would do, right? Look at the extent to which a medical store, the paperwork at the medical store matches the paperwork at a pharmacy. And so we also do this kind of audit. So we do a digital delivery tracking. So we place tracking devices within all of the trucks leaving central medical stores over the course of several months. and track 2,400 medicines going to 170 facilities, which is all the facilities that received medicines during that period of time. And now we're quite intentionally doing this at very high density and very quickly, very rapidly, and tracking most medicines. And because our attempt, again, is to treat this kind of like an audit, right? We're trying to understand over, for one large chunk of medicines, when are these medicines going missing, and trying to avoid the kind of learning process that you might expect to happen if audits happen over a long period of time. But traditional audits are only looking at this first stage, right? So the second thing we did is, okay, we want to understand the second stage of procurement, which is actually where most medicines go missing, which is what happens after medicines go into a pharmacy and before they get allocated to doctors and nurses within treatment wards. And to do this, what we did is we actually sent teams of people out into the field. One of our core partners on this, Brigitte Chimatira, I think is on the call. I might ask him some questions about this. And what we did is we sent people out into the field and had them visit 104 facilities and understand, using these digital tracking devices, whether or not the medicines were still within pharmacies or within treatment wards, or whether they disappeared at some point between the pharmacy and the treatment ward. Now, there's a third way that medicines might go missing, which is after this district health office gets the medicines, right? And this is also a very weak point on the supply chain, right? Is these are very informal kind of redistributions where district health offices are, getting phone calls or procurement orders from smaller health facility pharmacies, and much more informal kind of relationships. And so we also were interested in this chain, and so we did a separate audit of redeliveries from these district health offices to try to understand the extent to which medicines go missing at this point in the supply chain. And then finally, we were interested in when medicines get redistributed to private suppliers. So particularly in Malawi, this is going to private pharmacies and markets. And so we did another digital audit in person. We sent teams out to 143 private pharmacies and markets to identify the extent to which these government drugs are arriving in pharmacies and markets. This is some pictures of the audits taking place. This is an audit in a health facility, and this is an audit in a marketplace. All right, so let me talk a little bit about what we're finding so far. So this is a big data collection effort. We have over 10 gigabytes of data that's come from all of these different audits and tracking activities. So there's a lot of analysis that's going on. So I'm just gonna mention briefly a few things that we're finding in the data so far that I think are quite interesting, and I think suggest that this is potentially a very valuable way to go about understanding medicine theft. So first, what I'm showing you here is that first audit, right? So the extent to which medicines do not show up at the correct place during the delivery process, right? So I'm very specifically not using the term theft here, right? Because there's of course a number of reasons why deliveries could not show up where they're supposed to. The paperwork could not be in order. The driver could have mistakenly brought it to another clinic. There could be a lot of things going on. But as I'll hopefully convince you by the end of this presentation, there's at least some indication that a lot of what we're picking up is in fact some level of intentional diversion. But what we're finding with these deliveries is that in fact very few medicines disappeared at this point in the procurement chain. And then this is maybe not too surprising, right? This is the most well monitored and strongest aspect of the procurement chain. We have independent suppliers that are being observed fairly closely, that are doing a lot of deliveries. There's not necessarily a lot of opportunities for theft at this point in the procurement chain. Where we're seeing a lot more medicines go missing is during these in-person audits, right? So what happens after the medicines have arrived in facilities and before they get allocated to patients. And what we're finding is that on average, we're finding about 38% of medicines are going missing during this particular period of time. Again, this is a soft number. We're still going through a lot of these data, but this suggests that this is picking up a quite substantial level of missing medicines. I mean, what I'm showing you here on the left is the percentage of medicines that go missing by clinic, right? So this is, each of these bars represent the number of clinics based upon the percent of missing drugs, right? So the median clinic is receiving most of their most or all of the medicines that are storing and keeping the medicines that they were supposed to. But note that that we're seeing a lot of variation on this point, with quite a few places losing all of their medicines and quite a bit of variation in between. It's also interesting, what I'm showing you here on the right is this variation by medicine type. So these are the different medicines that we tracked in this activity, where we're seeing a lot more theft of things like ibuprofen and phenobarbital and amoxicillin, and less of these more either less valuable or more difficult to distribute type of items like syringes, gloves, and aspirin. And the final, just some preliminary analysis that we've done on the effects of this. So where we want to go with this research, of course, is trying to understand not just the scale of theft, but what consequences it has on public health and stockouts. And what I'm showing you here is some preliminary data and analysis that we've done looking at the relationship between medicine stockouts and this measure of diverted medicine. So by stockouts, so what I'm looking at here is this data on stockouts is measured using this baseline survey, which you're seeing the data for on the right here, which is citizens' observations about requested medicines being unavailable at clinics, right? So this is the proportion of visits that patients have made to clinics where the clinics have told them that needed medicines are unavailable, right? And as Mariana already emphasized, right, this is a huge issue within Malawi. We get around, I think it's 47% or 46% of citizens or patients have said that over the last 3 months that they've been unable to access needed medicines from their clinic. And this is also validated by other audits that have been done. This is not just us. This is a well-known issue within Malawi. But there's a lot of variation, right? Some clinics, it's 100%. And what I'm showing you here on the left is looking at those reported stockout rates, percentiles, and their relationship with the percentage of missing medicines. And what we're finding is that these places that are seeing huge levels of stockouts are also those places where we're seeing very large portions of medicines go missing. So if we look at the 80th percentile of stockout rates, right, this chunk of clinics where there's at the 80th percentile of stockout rates, we're finding that about on average, we're getting about 55% of medicines being observed by our audits as going missing, compared to low stockout clinics, we're getting about 15% missing medicines on average. So this suggests, one, that we're picking up something real, right? That we're picking up actual stockout issues at these clinics, but also that that we're demonstrating that that our technique of measuring corruption at a very precise clinic level is actually giving us a way to identify some of the ways in which theft and diversion and stockouts are impacting people's access to needed public health supplies. All right, so I'm going to talk very briefly about the impact evaluation that we're still analyzing. I'm not going to give you any data. I'm going to talk about what we're going to do next on that, and then I'll talk about some conclusions and then open it up for questions. So where we want to go with this, of course, is not just try to track medicines, but also try to understand whether these kind of technologies, electronic auditing technologies, can be a useful way to prevent theft. And one way you might think that this could be useful in preventing theft is that if people know that they're being observed, right, if we're increasing the risk of being caught for the diversion of medicines, this might in turn decrease the likelihood that someone is going to steal medicines from a public health clinic. And the impact evaluation that we did in this initial phase is is to use some branding on medicines themselves, informing public health officials about the tracking of medicines, right? So this is a picture of this, this tracking sticker. Just says this medicine is being tracked, sealing it can send you to prison. This medicine is property of the Malawi Ministry of Health. And then our expectation, right, is to the extent this is lifting people's expectations that they're going to be caught, this should in turn decrease the amount of theft and will give us some insight into the extent to which these kind of audit technologies might impact people's theft behavior in the real world. So as I said, we're still analyzing the data for this. We don't have a clear story for you yet, but in the coming weeks and months, hopefully we will have a draft paper talking about what we're finding from that impact evaluation. All right, so what do we draw from this? What are the next steps? Where do we go? So a couple things that I think we've come up with so far. One is, I think, the evidence we have both from the baseline survey and from our initial analysis suggests that diversion has severe public health consequences. And this is part due to these accountability gaps that Mariana mentioned, right? That we have weak capacity and information, both for these official institutions that are supposed to hold public health officials accountable, but also among citizens themselves and their ability to observe what's going on in their local community health clinics. Our pilot of these digital auditing technologies suggest that there are some advantages to traditional audits, and that they particularly can identify these kind of downstream types of diversion that happen and seem to do so effectively. Our initial analysis suggests there are some relationships between missing medicines and stockouts, and potentially other health issues. We're still looking into this further. Where do we go from here? So as I mentioned, we're looking at this impact evaluation. Additionally, we're looking forward to some future research and future partnerships, trying to understand ways we might better intervene to solve some of these information gaps, particularly among lower level stakeholders and accountability actors. And we think these kind of digital technologies can be a really powerful tool in making sure that citizens and accountability groups are informed about what medicines are arriving, when they're being ordered, and will in turn help these organizations and individuals to monitor what's happening at their local clinics. So thank you very much. And with that, I think I'll hand it off to you, Paul.
Great. Thanks very much indeed, Ryan and Mariana, for that very, very clear and fascinating presentation. It was obviously touching on issues of huge significance and importance, not just for Malawi, but also by implication for many other parts of the world as well. Ryan, do you want to stop sharing your screen so that we can then see people more easily? Let me invite people to ask questions. If you want to ask questions, you can either use the hands up facility within Zoom, or put your question into the chat. And we do already have a couple of questions in the chat. So Yukai, do you want to ask your question directly, or are you happy for me to read it out? It was in part answered, I guess, in the presentation, but it might be something that you could say a little bit more on, which is a question of the actual types of drugs that are stolen, used on the black market, etc. What drives that? I noticed that there was an antibiotic. Well, Yukai, you jump in and explore what you want to in regard to this.
Yeah, thank you, Paul, and thanks for the great presentation. I'm sorry, I probably might have missed those parts of the presentation because I actually didn't pick up or get clarity on the types of drugs that are popularly or largely stock out, and how that could be closely attributed to theft and just not government supplying enough. So yeah, I'm just quite interested, and also trying to find out the reason why, I can understand from a healthcare worker who's not being paid why they would sell the drugs. But I suppose on the part of beneficiaries who, if they are able to find the drugs for free, is it not in their interest to whistleblow and instead of paying in the black market price for something that they should be getting for free, if they do get it for free? That's it for me.
Sure. So I'll take the first question, and I'm happy, Mariana or Brigitte or Bright, if you want to jump in on the second question. So on the first question, I don't think we have any data at this point on what, it's difficult to answer your first question, right? So we don't have data from the audits from a large section of drugs. So what we did with the audits is purposely select drugs that our pilot activities suggested were more likely to be stolen. And so we were intentionally trying to understand patterns within likely stolen drugs rather than with a full sample of drugs. And we just didn't have large enough sample to do otherwise. We do have some data from the surveys around the extent to which how different types of drugs might or might not be missing from a clinic. So when a patient shows up, whether or not that medicine is missing. I don't think we've done any analysis yet trying to disaggregate that. Is that right, Mariana? Do either of you want to try to speak to this second question?
Sure, I can take a stab at this one. Hi, I'm Brigitte. I'm one of the PIs on the project. I'm at University of North Carolina, Chapel Hill. I am not on video because we have quarantined children who are also sick. So sorry. The time between the delivery and the audit at the clinic level, so the in-person audit, varied quite a bit, but it was somewhere between kind of 4 weeks and 10 weeks, basically, because we had some deliveries going out in later November, and then we kind of started the audit in late December, mid-December, I guess. And so we are, of course, going to kind of look at how variation in the time elapsed between the delivery and the in-person audit affects what we're seeing in the in-person audit. So the answer to the second question is, basically these devices were labeled as shipping devices, and also very clearly labeled that they needed to be returned to the Ministry of Health. So if the medication was used, then they should have been found. These devices should have been found in the bottom of the box or whatever, and they should have been kind of set aside. So they should have still been able to be found during the in-person audit. It's only if the box left the premises that we wouldn't have been able to find them. And of course, there are legitimate reasons for the box to leave the premises. So we, as Ryan explained, we have quite a few instances where the medicine was initially delivered by one of the trucks to a central health facility, and then they in turn kind of sub-delivered it to other health centers that are smaller. So that's, we're taking that kind of thing into account. But there are certainly instances where there's really just no good reason that the device cannot be found. I was wondering, Bright, do you want to talk very briefly, because I think this is so interesting, about what we found in terms of not being able to get the devices back and having them sort of go missing?
Yes, my name is Bright Chimatiro from Malawi. I'm one of the implementers of this particular project. A lot of things happened. As Brigitte Syme says, some gadgets have been missing, but looking at the particular areas where the gadgets are missing, it's pointing towards some unscrupulous means or mechanisms of trying to show that to conceal certain illicit activities, which I think, as indicated already by Ryan, that it's ongoing in terms of data analysis. But I want also to mention on the part of blowing the whistle that it's like a choice between life and death. You choose to blow the whistle, you can't get what you want to have. So it's like people choose to just procure the medicine, get their life and go on. More or less extortion type of corruption. Yeah, that's it.
Thanks very much, Marguerite. Does that answer your question? Yeah. Okay, so we have two further questions in the chat. I'm going to ask Steve and Mariam if they would like to say them out loud, or do you want me just to read them myself? Steve, are you still hearing this?
Yes, I am. Sorry, I was fumbling for my mute button. Yes, I think that there was an interesting piece of work that TSOC were doing. Was it TSOC? We're doing in Tanzania about patronage networks around health facilities, but also something that we're very aware of here. I'm in Malawi, have been for a very long time, and I'm very familiar with sort of the local setting. And clearly anybody who works in a health facility at any stage will be subject to this kind of pressure from their family and friends. Oh, you can get me these drugs, you can get me these drugs. Yes, they're free if you turn up sick at the health facility, but quite often that's a trek. And if you've got a contact at the health facility, it's just easy to get drugs that way. So, I mean, I would be really interested, and I'm really looking forward to the the final results of this, but I'd be very interested in what proportion of the missing drugs are actually ending up being sold in the private sector on a market, as opposed to just disappearing into the community. And I'm not sure that didn't actually come through in the research so far.
Thanks, Steve. That's a great question. Can we just take Mariam's as well, and then you can respond to both. So, Mariam, do you want to ask your question?
Thank you very much for your presentation. I am a research assistant working under what is now called Kamuzu University of Health Sciences. It was formerly called College of Medicine. And through the research that we've done so far is that they have started a program called EHIN, Electronic Health Intelligence Network, where different health facilities are able to place the orders through the system, but also they're able to manage how medicines are being distributed. The hope is that this system will work the same way that apparently the ARV administering system works, where whatever drug is being administered to a patient, you actually know who actually got it. The system is able to keep those records. But so far, it's only on facility level that this amount of drugs and this type of drugs have gone to this facility. So I wanted to know if through your research so far, you've come across this, and if so, how effective has it been to minimize mismanagement of drugs and other medical supplies?
Great, and thanks very much. And can we just say there's a question from Dina as well here. So Dina, do you want to set that out in slightly more fully than in the chat?
I'm very sorry. I'm right now on the bus, so I can't talk very easily. But I caught that you are associating the type of test with stockouts. But I was wondering whether you looked at any other characteristics of the facility. For example, places where we're finding from our initial research, places with more shortage of doctors and more nurses may have different type of leakages from others. So I wonder whether you looked at any of those characteristics of facilities. Thank you.
Great. So some nice meaty questions there for you to get into.
Yeah. These are all great questions. So I can get started, and Mariana, Brigitte, or Bright, if you want to jump in on anything, feel free. I think to go to Steve's question. So this question on personal networks, certainly you're right. This is certainly how a lot of this this theft is happening. It's quite difficult. So to be clear, right? What we can identify with the audits that we're doing is what happens to stocked medicines. So what happens to a physical bottle of pills, or a physical vaccine or something, right? What we can't do is identify what happens, how frequently does a pharmacist take 3 pills out of that bottle and go and bring them home to one of his or her family members. Now, certainly this would be a really interesting thing to do, but just with the technology we're using, we can't identify it. And I certainly agree with you that this is a big part of what's going on. I think it's less of an issue, so arguably we're going to pick up these kind of bigger kinds of theft and not this kind of low level stuff. With respect to how often these are sold in markets, so we're still analyzing these data. One thing that makes this a little bit challenging is we don't have a full sample of this, right? So ideally, to do this properly, right, you'd want to go and do audits at every single market and every single pharmacy across Malawi. And actually, even this wouldn't be great. Ideal, because you'd have to send a bunch of drones over Mozambique as well to try and pick up a lot of this. So what we're doing instead is trying to do audits at markets and pharmacies that are nearby clinics, right? It's kind of the most likely scenario for this kind of selling to go on. And so, we're finding some instances of this happening. It's going to be difficult, though, I think, to answer your question precisely about the exact proportion that's sold versus distributed in other ways. Anyone else want to speak to those? Okay. So Mariam, I'm not familiar with this EHIN system. I know there has been some talk in Malawi for a while and doing this kind of electronic logistics management. Mariana, you may be more familiar with this than I.
So I think in one of our meetings, someone mentioned they were starting with the system, but we haven't talked much about what happened later, especially in the last 2 years. That was definitely in 2019, I think, and we can definitely look more into this. Maybe we can get data if you can combine the data from their system to the data we have from the follow-up audits we're doing. I think that could actually just make our research even better.
Yeah, and if you want to send me an email, Mariam, I'd be very interested in anything you have on this system and any work that's been done on how effective it's been. I mean, certainly, I think this is probably where the health system in Malawi should ideally go. There's a lot of, I think, logistics and capacity issues with making this effective, as you know. But if you look at why do we see so little theft, for instance, in Rwanda, and part of the reason is we have a very, very, very watertight electronic tracking system from end to end. The challenge with these, of course, is again, it's quite difficult to use these kind of logistics systems to monitor low-level theft. So it might end up not having that large of an impact. To speak to Dina's question about types of facilities, I mean, this is certainly stuff we want to do. We don't really have a good answer to your question yet. So this is certainly one of the things we want to work on in the coming weeks is trying to understand what kinds of facilities are more likely to have theft. And the biggest thing we found so far is just this relationship between stockouts and theft. But certainly we'd be interested in looking at how this might correlate with other kinds of shady activities or staffing issues. I think that's an interesting question.
That's great. Thanks very much. We've got one question, which I think will have to be the last given time constraints. So Vina, sorry if I've completely mispronounced your name, my apologies, but please do go ahead and ask your question.
Oh, sorry, I'm on mute. Hi, Paul. Yeah, it's Weena actually, and I'm also in Malawi. I just wanted to share, thanks for the presentation, Ryan, and we met a few days ago in a joint call. I just wanted to share with you something that might be interesting as you go forward. That I work with an organization called Options, and a few back in, I think it was about 2015, we also looked at, explored how selected resources flowed through district hospitals and health facilities. Drugs were included, but also patient food. We looked at how contracting was done in terms of vehicle maintenance, you know, kind of ambulances, etc. And one theme that came up was, you know, kind of normative attitudes toward public goods and services. So anything that was seen to be from government was seen, there's a socio-cultural value, it was seen as being free. And much of the essential drugs in Malawi are heavily donor financed. I saw in the chat box, there was mention of family planning commodities as well, that are primarily financed by donors. But there was this kind of attitude that, you know, free goods or services can be, they don't have an owner, so they're kind of a shared resource, and so they're, you know, because they're shared, they're often subject to, you know, overuse or under protection. So I'm just thinking about the comment Steve made, this notion of, you know, helping your family or helping friends in the community. You're taking something that doesn't really belong, you know, it's there and it's free, and it's being shared, you know, amongst family in the community. But if you multiply a handful of paracetamol or ibuprofen by the sheer number of health facilities in Malawi in the grand scale, that is a lot of drugs that are disappearing. I also wanted to just mention on the whistleblowing, there's been a few studies that have done in Malawi, and there's quite a few initiatives available for the public to whistleblow, but to be effective, you require 3 states of actors, if you like, the whistleblowers and the investigators. But then you've got the action takers, and what we're finding here is that kind of the inappropriate or lack of sanctions, the action or inaction against wrongdoers that's missing in that kind of whistleblowing framework. So I just wanted to speak to those 2 points in light of this discussion. Thank you.
Thanks, Rainer. Do you want to just respond briefly, Ryan?
Yeah, I mean, those are great points, Weena, and hopefully we have many future conversations, because I'd be curious exploring your thoughts on those further. I mean, on this norm issue is interesting, and I'd be curious if anyone else's thoughts on this. But I think, you know, I mean, certainly there is, you know, my sense is you know, you're certainly right that there is a little bit of an expectation that, you know, you share with family and friends because it's, you know, it's free government goods or free donor goods. But at the same time, if you go and look at what citizens say and what citizens' opinions are about theft, I mean, it's quite startling in our, you know, interviews and surveys how frequently patients both see theft as a major reason why they don't get public health care, and also almost overwhelmingly say they're willing to do something about it, or willing to report to the chief or the village headman. So yeah, these norms exist and maybe a constraint. I guess I'm a little bit skeptical that they're a binding constraint, given how much patients really seem to see this as a kind of existential crisis in the Malawi public health system. At least that's my sense.
Can I just weigh in on that very quickly? So I absolutely agree with Weena, and I saw this in my other work on corruption in Malawi. And I think the distinction here is the norms held by the officials versus the perceptions of the citizens. So I agree that the perceptions of the officials and the norm there is that, you know, government items are free to all, and, you know, we see the use of government property for personal use, for patronage networks in a lot of different areas of public life in Malawi. But that's not necessarily incompatible with citizens still thinking like theft is a problem, and we know it adds up and it's interfering with our healthcare.
Thanks very much. I'm really sorry because we've gone over time, and at least some of us have other things that we need to move on to. So can I invite anybody who still has questions and would like to follow up to contact Ryan and his colleagues directly. But let me just close by thanking Ryan, Mariana, Brigitte, Bright for the fantastic presentation of work that you've been doing, to the audience for your engagement and some really good questions. And we all look forward to seeing how this project pans out over the coming weeks and months. So thank you very much indeed, and look forward to seeing you soon.